Thank you, Ajit, for the very kind introduction. I'm really happy to be part of this conference, and I'll try to give you in the next 10 minutes an overview of important percutaneous device options that we have for the management of heart failure. Heart failure, as we all know, is a global pandemic. Only in the United States, we estimate that in 2020, we had 6.7 million people suffering from heart failure, and the projection is by 2030 to have 8.5 million. And if you look at the admission, hospitalizations, and ED visits, about every year we get 1.2 million people hitting our EDs with symptoms of heart failure. And medical therapy is, of course, the foundational treatment for heart failure. And there are 4 groups of medications that prior in this conference we have outlined that can be used for heart failure. And they are reducing the preload of the heart, they're reducing the afterload, they're improving the oxygen demand, improving coronary perfusion, and in certain occasions they can lead to reverse cardiac remodeling. However, there are certain limitations in the use of medical therapies, such as difficulty to uptitrate them. Some people do not tolerate them. Patient non-adherence. Sometimes we cannot target all the pathophysiologic pathways that are related to heart failure. And of course, despite using all these medications, we've noticed that there is still high morbidity and mortality in our population. So the question is, can device therapies help us improve our morbidity and mortality, and in some occasions target those areas that the medical therapy cannot reach? And I will stratify the device. I will present them in a way that they affect the pathophysiology of heart failure. First, I'm going to present you devices that they reduce the preload. One example like that is the Percutaneous system. This is an inflatable balloon that is placed in the superior vena cava, and it deflates at certain seconds in the cardiac cycle, and the goal is to reduce the flow to the heart periodically. And why is this important? Because we have noticed in pre-clinical studies that by reducing the filling, the preload to the heart, the filling of the left ventricle can improve, the output can improve, and also it can lead to decongestion of the peripheral organs. The study that studied that is the Venus HF trial. It's an early feasibility trial of 41 patients. And of course, it was a safety trial, but also they looked into secondary endpoints such as reduction in the filling pressures and increase in urine output. And indeed, as you can see on the panel on the left, there was a reduction in the right atrial pressure, in the wedge pressure, and there was an increase in urine output. And of course, there was an improvement in the symptoms of patients that were receiving the treatment with the Percutaneous device. So it's a very promising treatment that we will see more and more in the future. The next type of device is those that they reduce the afterload and increase the cardiac output. One of those devices is the intra-aortic entrainment pump called Aortix. This is a pump that is placed in the descending aorta above the renal arteries, and it provides increased flows to the renal arteries, improving the kidney perfusion. And in parallel, it decreases the afterload of the heart, increasing the performance of the native heart. And you will see in preliminary data that there was an improvement in eGFR in patients that used the Aortix device, and a reduction in NT-proBNP suggestive of reduction of the filling pressures of the left ventricle. And of course, the symptoms of dyspnea improved. Another type of device like that is the second heart assist. That's an impeller device placed again in the descending aorta above the renal arteries through a 13 French catheter. It spins 7,500 times per minute and provides a 2.5 liters flow to the renal arteries, also reducing the afterload of the heart. And what promises is to be a wireless technology, so we can get rid of the wire and the patient can be more mobile using this device. More data to come on that. Another group of devices are those that they reduce the left atrial filling pressures. And why is this important? Because increasing left atrial filling pressures is one of the main mechanisms that people that have heart failure with preserved ejection fraction get short of breath. One type of device is the Corvia device. This device creates a shunt between the left and the right atrium. So whenever the pressures in the left atrium increase in exercise, then the blood shunts from the left to the right, relieving the pressure in the left atrium and relieving the pressures in the pulmonary circulation. The study that examined the effect of this device is the Reduced Lab Heart Failure 2 trial. It was a one-to-one randomized open-label trial. People that they had ejection fraction of more than 40% and elevated wedge pressure on exercise, more than 25, were randomized. We were able to get 626 patients in the trial. And the primary endpoint was a composite endpoint of cardiovascular death, non-fatal ischemic stroke at 12 months, and rate of heart failure hospitalizations. And unfortunately, we did not see any signal of difference between the two groups, the one that received the device versus that got the sham procedure. But when we did subgroup analysis, then we were able to identify one group of patients that they do not increase their pulmonary vascular resistance on exercise, and they stay less than 1.7 Woods units. And you will see that in this particular group, that they do not have latent pulmonary vascular resistance, they improved their symptoms and they felt better with this device. So there's a new trial now going on, the Responder HF trial, with a goal to target this group and see in a randomized manner if people can benefit from the Corvia device. Devices that redistribute the fluid between the intravascular and the extravascular space is also another possibility. One of those cases is the endovascular ablation of the right greater splanchnic nerve, and that prevents from blood getting from the splanchnic to the systemic venous circulation. And this redistribution that is not happening makes the patient not feel short of breath. And we can see in the rebalanced heart failure trial, the preliminary data showing an improvement in the New York Heart Association class in patients that received the splanchnic ablation, and of course, improvements in the KCCQ questionnaire. Intracellular calcium handling modification is another way that we can help people with heart failure. The cardiac contractility modulation device is one of those devices that is placed, the generator is placed in the subclavian area like a pacemaker, and then two wires are stimulating the heart during the non-exciting cycle. And that can improve the calcium handling, and that can improve the contractility, as we can see from the data from the FIX-HF trial. Ongoing trials now is the AIM Higher trial that targets people with an ejection fraction of 40 to 60%, and the Integra D trial that combines the CCM device with a defibrillator and aims to see if that can help the patients and prevent, of course, from sudden cardiac deaths. Finally, we have the Autonomic system modulators. These are devices that aim to restore the imbalance between the sympathetic and the parasympathetic system. In heart failure, we have excessive stimulation of the sympathetic system and suppression of the parasympathetic system. The Barostim Neo system is targeting people with EF of less than 35%, being New York Association 2 or 3 despite optimal medical therapy. And by simulating the parasympathetic system, we've noticed in our data that the exercise capacity improves, the quality of life based on the 6-minute walk test improves, and the NT-proBNP also goes down. So this is another promising therapy for people with heart failure. Finally, another device along the same group is the Cardionomics cardiac plexus stimulator. Is placed through the IJ into the pulmonary artery, the right pulmonary artery, and I guess delivering electrical stimuli tries to restore the imbalance between the sympathetic and the parasympathetic system. And preliminary data have shown that it leads to reduction of the PA pressures and improvement of the contractility of the heart based on the DP, DT max without increasing the heart rate. In summary, heart failure is a global pandemic affecting an increasing number of people every year. Medical therapy remains the foundation of heart failure treatment despite the limitations. And novel devices can target structural and neurohormonal abnormalities that they are not amenable to medical therapy. And the device-based therapies are not to replace the medical therapies, but rather to complement them and fill in the gaps of the medical therapy. Thank you very much.